So Bill's going to talk about the legislation and the recent legislation, 2,400 pages. He spent all night reading it. I know it. The next panelist up will be Dr. Jay Lee. He's past president of the California Academy of Family Physician, excuse me. He's now the CMO of the Venice Family Clinic. We welcome him to the UCLA environment because we're very involved. And he was instrumental in doing practice transformation at Memorial Care and in the faculty in family medicine at Long Beach Memorial. I've asked him to talk about the solo and the small group and the rural. How do these players adapt to MACRA? What do they need to do? What do they need to learn? And finally, Dr. Adam Solomon is our CMO for the Memorial Care Medical Foundation. And he's going to talk about a larger group and how we're prepared at Memorial to go right into the APM model. Now, there's some definitions that have to be given. I just said APM, alternative payment model. There's another model, MIPS, the Merit Incentive Plan, part of MACRA. That will be discussed. And so finally, just so you know, I am pleased to be on faculty here at the School of Public Health, teaching in the EMPH program and the Health Certificate Graduate Program. And being an alumni now approaching 48 years. So I'm very pleased that I can still be connected here. I am the executive director at Saddleback Memorial Medical Center, part of Memorial Healthcare System. I'm in charge of strategic development, physician strategy, engagement, and development. And I've been in ambulatory care all my life, and I had the pleasure of going through the education here to do that. So I'm going to turn the mic over to Bill, and we're going to have a question and answer session after they're finished. They'll come up here, and we'll have roving mics. So Bill, thank you.
Thank you. Okay. Ooh, my mic is hot. Okay. Good evening, everybody. How are you? Okay. MACRA in 10 minutes or less. All right. So why MACRA? If you go back to Massachusetts in the middle of the last decade when they did their universal health care reform, which of course turned out to be somewhat of a chassis for the Affordable Care Act, the Massachusetts plan was based on the expansion of coverage and then putting off all the tough issues around cost control and reform of the delivery system in Massachusetts. Those came later. That's a corollary to MACRA. Now, we had the Affordable Care Act. It did expand coverage. It's worked well to expand coverage so far, but costs are escalating at the national level, and so MACRA. We have the silver tsunami. We have 10,000 seniors becoming eligible for Medicare every day, day after day after day. And Congress is approaching this from a bottom line budgetary cost issue. MACRA is designed to control cost escalation in Medicare and also in Medicaid across the US. So it's important not to lose sight of who the ultimate beneficiary of MACRA will be. It will be the government because it is a cost control measure. Now, if I'm assuming a lot of you have read or read Dr. Atul Gawande's articles in the New Yorker. You're familiar with the cost conundrum. I've seen a lot of good heads. That's great. You remember the famous article in 2009 about McAllen, Texas, that pointed out the problems with a runaway fee-for-service system that wasn't accountable. It's very interesting, but after all that light was shed on McAllen, they got their act together and they've actually reformed their delivery system regionally very well. So MACRA now is that next step for the entire country, for all the physicians practicing in Medicare, and very soon, I think, physicians who practice in Medicaid, Medi-Cal here in California. So What does it do? It takes us off of the fee-for-service schedule, which is pay by the widget of service, to a value-based model, as Avram was alluding to. What does that mean? It means that increasingly, it's not just the delivery of service, it's how the service is delivered, it's what the cost was, it's the outcome. And the government is trying to figure out how to set up a rule system to govern that. MACRA is one of our first attempts to do this. And so it takes us over a period of years in an escalating fashion off of pure fee-for-service in Medicare, Part B, and takes us to a system of carrots and sticks, bonuses and penalties for the average solo and small group practitioner in America who's serving seniors. As you can see from the chart, over time, the potential for bonuses and penalties gets larger. It's a transitional program. There is also the other side of the issue about reforming the delivery system, moving away from perhaps small and solo practice delivery to integrated and coordinated care, which requires larger organizations who should possibly be paid at an organizational level. So sink or swim together, so to speak. And MACRA recognizes that transition. So you have the advanced payment model, which is designed to reward organizations as well. And since it is a reward-only program, you notice in the right column, there's only pluses. That's the incentive for doctors to move into organized systems of care. Pretty self-evident, right? Can we go home now? Because from here on, it gets really murky. Okay. So it is taking from, let's focus on MIPS for now. And Jay is going to do a deeper dive on MIPS as well from the physician perspective. It is merging 3 pre-existing quality measurement programs that have existed for some time. And it is merging them over time into this scoring model that commences 2019. And you can see from the split in percentages, its cost, its quality, its adoption of improvement activities. It's starting to get at a measurement model that will somehow reward value over volume, outcomes over delivery of widgets with no accountability. And this will be an evolving model for the rest of our lives, which is great because we're all in healthcare, right? So we'll all be employed until we can no longer show up for work. Now, the APM side of this is more difficult. You can't just form a group. You can't just escape the penalties of MIPS and get into the land of bonuses, ever-flowing bonuses on the APM side. Not all groups will be qualified as APMs. And when the final rule came out 2 weeks ago on the 14th of October, it solidified the types of organizations that can be regarded as APMs, at least for now. It left the door open for the development of other advanced payment models in the future, but it closed a very large door for a lot of very sophisticated delivery systems in California and across the country when it excluded any participation by those groups in the Medicare Advantage side, the capitated HMO side of Medicare. And so for the foreseeable future, until any further action is taken by the Congress or CMS, any of our large organizations in California that perform so well in Medicare Advantage are not going to get credit for that under this program. They will have to participate on the Medicare B side as well, or be subject to the MIPS up and down. So that is an unresolved issue, and I'm sure that eventually it will be resolved. I think I'll go out on a limb and say the reason why is that ultimately Medicaid managed care is going to be folded into MACRA fairly quickly. And that is an emerging capitated managed care model, not just in California, but across the US. And so to move that into MACRA on the Medicaid level, I think it's only fair to move Medicare Advantage into the MACRA model ultimately as well. So that's my hope, and I think that's where things will go. All right. The final rule, Avram said it was over 2,000 pages. It's actually just about as long as the original Affordable Care Act. And it's just one little regulation along the way in the Affordable Care Act story. And that gives you an idea of how complex the rulemaking is. Congress received, or CMS received 4,000 written comments on this rule when it was proposed last year. They responded to most of those in the final rulemaking document, which is why it's probably 2,400 pages long. They also interviewed about 100,000 physicians along the way. So one of the things they heard was, you're moving too fast. And so they announced and finalized on October 14th the Pick Your Pace transition, which allows small group and solo practitioners, oh, I'm way behind. Okay. It's a slow transition, what can I say? Okay. It allows them to move in over time, and you can see how it's laid out here. That lessens the immediate impact somewhat, gives us a little breathing room to organize a little bit better. It's still been very, very difficult, for example, for a lot of physician groups in California to figure out whether to apply for the APM status and under which category. A lot of them did not do it for 2017, and now will have to work very quickly before the second quarter of next year to determine if they'll apply for 2018. And you can see the reason, if you don't apply, you land back on the MIPS side where you have the potential for penalties and not just bonuses. So how to get out of MIPS. You've got your Medicare Part B participation. You have this low volume threshold model now that's under the final rule, or you can qualify in an advanced alternative payment model. To become an APM, you have to meet these 4 criteria. You have to be something like a next-gen ACO, which Adam will talk about, or a Medicare Shared Savings ACO in Track 2 or Track 3, possibly in Track 1 Plus when they figure that one out. You have to have a much more rigid level of certified EMR adoption than is presently the case, particularly among specialists out in the physician community. And they're still figuring out the nominal risk. They are still not allowing, as I said, fully capitated models, even though that is the ultimate goal, moving MACRA from fee-for-service into capitated payment. Capitated payment is still not part of this at the present time. Advanced APMs eligible for the 5% MACRA bonus. These are the types of APM models that are allowed. And then there's a transition period for the thresholds, just like there was for the individual and small group physicians in MIPS. There is a transition threshold that begins 2019 and extends to 2023 and beyond, where your mix of payments to the APM starts at 25% for the lower threshold and eventually ends up in 2023 as 75% revenue to qualify. So it's driving individual physicians into organizations, driving organizations into greater and greater APM participation. So the final rule that came out that people are still sifting through, what we know so far, is that it lessens the burden for the initial transition over the next 2 years. It builds off existing programs in Medicare Part B, all the quality programs, and it is in a transition year. Most of the people who wrote this regulation will probably move on at the end of the administration here, and we'll have a whole new crew starting next year, maybe some new perspectives, and we'll have a new Congress too. Remember, this was the one bipartisan legislation that got out of this Congress. There have been very few bills that have emerged from this Congress on a bipartisan level, and this is probably the largest, most impactful piece of legislation that this Congress has produced. And that says something. It says something that in the future with the next Congress, it is likely that they will continue to act on this rule and develop it, even though they may not agree on the underlying Affordable Care Act and may continue the stalemate on that. At least on delivery system reform and physician payment, they are moving forward in a bipartisan manner. And with that, I will turn it over to Jay.